Oh, good. Good afternoon. To be or not to be, that is the question. Today, we are tackling an equally pressing concern: to give or not to give anthracyclines. This has been a debate for about 15 or 20 years, and by 8 o'clock Greenwich Mean Time on the 6th of December, 2023, in the city of San Antonio, Texas, we are going to answer this question. I'm Hal Burstein from Dana-Farber Cancer Institute. Our discussants are going to be two of the most extraordinary clinical investigators there are, Professor Martine Piccart from Institut Jules Bordes in Belgium, and Professor Virginia Borges from the University of Colorado outside of Denver. They will be speaking for and against anthracycline use in the adjuvant setting, respectively. For those of you who are joining us, pull out your iPhone. There will be an opportunity after the remarks to answer a couple of clinical poll questions, and we have intentionally left an actual chunk of time so that people can raise questions. You may send them in digitally, or you can go to a microphone, and we will do our best to tackle them as a group. Let me begin with a few remarks about how we got here. 50 years ago, in 1973, was the first major report of adriamycin, or doxorubicin, as a treatment for advanced breast cancer. It was part of a larger series looking at a variety of human tumors, including lymphoma and sarcoma, and anthracyclines showed substantial activity in each of those diseases, including breast cancer, with an initial response rate on the order of about 32%. In this very first study, it was already noted that there were EKG changes, that there was a risk of heart failure related to high doses or high exposures to anthracycline, and that these drugs had activity. These regimens that got subsequently built around doxorubicin continue to be used today, and it became the backbone of things that we'll be talking about in breast cancer, as well as things like CHOP chemotherapy for lymphoma. 2 years later, there was a report where they combined anthracyclines, doxorubicin, with cyclophosphamide for advanced breast cancer. Steve Jones was the first author here. They showed in a series of about 50 patients an astonishing 80% response rate. It was the most active regimen then yet seen in advanced breast cancer. And again, were noted what was considered acceptable toxicity, but oncologists always say whatever regimen they're describing that the toxicity was acceptable. However, there was substantial nausea, myelosuppression, alopecia, and heart failure. Now, as the development of adjuvant regimens proceeded in the 70s and 80s, CMF became the mainstay of most of the early phase chemotherapy adjuvant trials. And then there were several studies, and I'm only focusing on a few of the many, many studies that are in the literature, but there are several that then compared AC chemotherapy, as we all came to know it, versus CMF. One of them was NSABP B15, which actually showed no difference between 6 months of oral CMF or classic Milan-type CMF versus 4 cycles of AC. And because AC was shorter and in many respects easier to give, it became a commonly used regimen. A follow-on study, NSABP B23, again compared AC versus CMF in node-negative, ER-negative breast cancer, and again showed comparable results, not one better or worse, but essentially the same. Finally, at this meeting many years ago, we saw the intergroup 0102 trial, which compared CMF versus CAF in node-positive breast cancer. This study had a complicated design with or without tamoxifen and included ER-negative and ER-positive patients. But with 10-year follow-up or more, it showed a 2 to 3% improvement in disease-free and overall survival, favoring the anthracycline-based regimen. Already going back 15 years, there were efforts to try and find biomarkers that might identify which patients might uniquely need anthracycline-based chemotherapy. Interestingly, HER2 in the pre-trastuzumab era emerged as a relatively robust biomarker in that patients whose tumors were HER2 amplified or positive did seem to derive more benefit with anthracyclines compared to CMF. And by contrast, tumors that were HER2 negative, there was really no major difference between an alkylator-based regimen and AC. So anthracyclines became a mainstay of our current programs. They are the backbone of many of, if not all, of our modern chemotherapy regimens. The toxicities and the need to give these drugs prompted major innovations in supportive care, including development of many antiemetics and growth factors that we now use routinely. And of course, anthracyclines became notorious in the patient community for the major side effects, affectionately known as the Red Devil. Now, there were some further iterations, namely the addition of taxanes to core AC regimens. CLGB 9344 was one of, again, many studies that looked at this kind of question, but showed that sequential addition of paclitaxel, but not dose escalation of doxorubicin, would achieve improvements in in event-free survival. And with that in hand, several studies looked at changing the schedule of either anthracyclines and taxanes or simply taxanes to what we now would call a dose-dense schedule, CLGB 9741, looking at every 2-week versus every 3-week administration of ACT, versus ECOG 1199, which looked at weekly paclitaxel after AC, showing that in this core backbone regimen, you could adjust the schedule and improve outcomes for patients. So based on that, we had the evolution of a huge number of regimens, and again, these are just exemplars. In Europe, they largely used epirubicin. In the US, they largely used doxorubicin. Globally, there was a mixed match of all these different regimens. But what began with AC was then derivatized to include AC followed by a taxane, and then dose-dense ACT or AC followed by weekly paclitaxel became very standard regimens in the US. Well, what about the non-anthracycline regimens? So one innovation was the development of a docetaxel and cyclophosphamide regimen called TC, which was compared head-to-head with AC, and we'll hear more about that, perhaps found to be a little bit better. Another innovation was prompted by the development of adjuvant trastuzumab. The major reports for those trials in the first generation came out at the ASCO meeting in 2005. And largely, they piggybacked the trastuzumab compound onto the existing ACT platform. So you had ACTH, or sequential ACT and then H. Though there was the novel regimen in the BCIRG 006 trial of docetaxel, carboplatin, trastuzumab, and each of those has subsequently seen the addition of pertuzumab to the regimen when that became identified as an important drug. There were some efforts to get rid of the anthracyclines here, namely the TH regimen, where we simply lopped off the AC, leaving the paclitaxel trastuzumab regimen, which has become widely used for lower risk HER2-positive breast cancer. Finally, of course, there's now the addition of immunotherapy, and the Keynote 522 regimen adds pembrolizumab onto a sequential program of taxane, carboplatin, followed by AC. So that's what our major regimens look like these days that involve anthracyclines. They are sequential treatments of anthracyclines and taxanes with or without an additional biological agent, typically given on a dose-dense or weekly schedule, and they remain the gold standard, as we've heard this morning already at this meeting, and all of you who are in clinical practice routinely encounter. In addition, we now have a cohort of regimens that are not anthracycline-based, including TCHP, or the TH regimen for HER2-positive tumors, and the docetaxel cytoxan regimen, or TC, as another option. Now, after widespread use of anthracyclines for truly decades, beginning around 2005, we saw a major shift in patterns of practice. Here in the United States, the blue lines representing the frequency of use of anthracycline-based regimen all of a sudden began to nosedive, and there was an upsurge in non-anthracycline-based regimens like TCH or TC. What happened in 2005? Well, as this audience knows well, we saw the BCIRG 006 trial of ACTH versus TCH presented, and we also had the publication of the TC versus AC trial. So we had created major non-anthracycline options for many types of breast cancer. Since then, there is a regularly scheduled controversy and comment editorial or otherwise opinion piece published in our leading journals looking at whether or not we still need anthracyclines. Are we ready to let go of them? Have we rediscovered a new opportunity such that anthracyclines are striking back? So on and so forth. And that sets the stage for today's discussion. Here's some questions I'm hoping our discussants will address. First, have recent therapeutic innovations rendered anthracyclines obsolete? We have better chemotherapy agents and better chemotherapy schedules, now using carboplatin and taxanes. We have added anti-HER2 antibodies, which in many respects seem like a trump card for tumors that are HER2 positive. We've now added immunotherapy frequently for stage 2 or 3 triple-negative breast cancer. And we've actually made major improvements in our innovations for ER-positive disease, including ovarian function suppression, the use of AIs, and the use of adjuvant CDK4/6 inhibitors. Have we done enough to mitigate the side effects and risks of these drugs, or is there still opportunity to do that more? Are there other clinical factors or biological features that we should look at? Can we define a tumor group within a subset or a group where anthracyclines are still important? Can we define clinical features such as stage or comorbid health problems or some other to-be-determined biomarker that would uniquely identify tumors that do or do not need anthracyclines? And finally, what are the global health implications of discussing giving up on a drug which is widely available, inexpensive, proven efficacious, and is used to treat the most widely diagnosed tumor type in women around the world? As Jack Cusick pointed out this morning, over 2 million cases a year globally, a growing number in historically low and middle income countries. So to answer those questions, we have some superb speakers. We'll start with Professor Martine Piccart, who will give the case for anthracyclines. Martine.
Thank you very much, Hal. Dear colleagues, good afternoon. I first would like to thank the scientific committee for inviting me to participate in this debate, and I would also like to thank my colleague Guilherme, who is a Brazilian oncologist, who helped me with this presentation. So here are my disclosures, which have no relevance to today's discussion. So let me start by examining the NCCN guidelines, which, as you know, are very popular in this country. They are telling us that anthracycline regimens are still preferred in many patients with HER2-negative breast cancer. In contrast, for HER2-positive disease, they state that anthracyclines can be useful in certain circumstances. So, why is the landscape of treatment guidelines in the US, but also in many other regions of the world, for early breast cancer still dominated by anthracyclines? In the next 10 or 15 minutes, I will give you 7 solid arguments for this fact. Number 1 argument, the benefit is robustly shown by the EBCTCG individual patient level meta-analysis. Here you see the results of the comparison between taxane-based regimens and anthracycline-based regimens published in April 2023. There were 23 eligible trials, but 15 trials could produce patient individual data, and that was in a total of more than 18,000 women. And you can see on the left that half of these women had node-positive breast cancer, 2/3 had hormone receptor-positive tumors, and 14% had HER2-positive tumors. Please note that no woman there was older than 60, and that the most common comparator was 6 cycles of docetaxel cyclophosphamide. And what you can see is that recurrence rates at 10 years were 14% lower on average with the addition of anthracyclines, and this was statistically significant. Now, although the most striking benefit from anthracycline was seen in the concomitant anthracycline-taxane regimens, which we do not prescribe very often today, I thought it was interesting to show that the benefits seem to be independent of ER status and also of nodal status. Now, of course, today we are no longer talking about breast cancer as one disease. So let us examine separately HER2-negative disease on one hand and HER2-positive disease on the other hand. Argument number 2. In HER2-negative disease, trials designed to demonstrate non-inferiority of non-anthracycline-based regimens have failed. And this is a powerful, very well-designed joint analysis of 3 adjuvant US trials, which was in fact designed to assess the non-inferiority of the non-anthracycline arm in terms of invasive disease-free survival. As you can see, the taxane regimen in all the trials was TC times 6, but there were a variety of anthracycline regimens allowed, such as TAC for 6 courses, and then 3 versions of the sequential AC paclitaxel regimen. A hazard ratio greater than 1.18 was predefined as demonstrating inferiority of the non-anthracycline regimen. Now, with an observed hazard ratio of 1.23, the TC regimen had to be declared as inferior. If you look at the right part of the slide, you see this forest plot, which would suggest that the benefit of the anthracycline regimens was more striking in ER-negative disease and also in patients with bulky disease, with a lot of positive notes. Argument number 3, in HER2-positive disease, no trial has been designed and statistically powered to demonstrate non-inferiority of non-anthracycline-based regimens. And this is also true for this famous BCRG-006 trial, which is one of the first-generation adjuvant trastuzumab trials. And as you know, the trials showed that the 2 trastuzumab-containing arms were superior to the control arm, AC, followed by docetaxel. But of course, this trial was never powered to compare the 2 trastuzumab-containing arms. Nevertheless, you can see here the 10-year results show very similar outcomes for these 2 trastuzumab-containing arms. There was a 2% difference in favor of the anthracycline arm. But of course, there was less toxicity associated with the TCH regimen, particularly less cardiotoxicity. And this trial had a very big impact on the US medical oncology community, and oncologists in this country started to walk away from anthracycline, particularly in HER2-positive disease. In Europe, the anthracycline-based regimens continued to be quite popular, and they started to be challenged only in the era of dual HER2 blockade. And this is an elegant, although relatively small, randomized phase 3 trial conducted in the Netherlands that compared an anthracycline-containing neoadjuvant regimen to a non-anthracycline containing neoadjuvant regimen given both with pertuzumab and trastuzumab. And as you can see, the trial was designed to demonstrate superiority of the anthracycline arm in terms of pathological complete response rate. The trial did not meet its primary endpoint, and the PCR rates were virtually identical, as were the 3-year event-free survival rates. But again, the trial was not at all powered to demonstrate non-inferiority, not powered to detect differences in event-free survival or overall survival. And oncologists should remember their statistical courses at the university. You have to look at the 95% confidence intervals, which were overlapping. And there was also a relatively low cumulative dose of epirubicin in this trial, 270 milligram per meter square. Now, this is a very important and powerful single-arm trial, which I believe has the potential to validate a non-anthracycline regimen for patients with HER2-positive breast cancer. CompassHER2, as you can see, gives to women with stage 2 and 3 HER2-positive breast cancer, 4 cycles of taxane given in combination with trastuzumab and pertuzumab. And for patients who show a pathological complete response, no further chemotherapy is given, but the patients have, of course, to complete 1 year of dual HER2 blockade. And for this trial to be considered a success, the 3-year relapse-free survival rate has to be in excess of 92%, both for patients with ER-positive tumors and patients with ER-negative tumors. So we have to wait. The results probably will be there in 3 years, I suppose. Argument number 4, targeted drugs we use today have demonstrated efficacy on top of an anthracycline backbone. You know very well that famous trials that have shown the benefit of dual HER2 blockade, such as Neosphere and Affinity, used anthracyclines in more than 75% of the patients. This was also true for the famous Catherine trial that demonstrated the benefit of TDM1 in patients with residual disease following a neoadjuvant chemotherapy regimen with trastuzumab, and the Extenet trial, which demonstrated a benefit from neratinib given after 1 year of trastuzumab, is also a trial with a massive use of anthracycline. And the same is true for the famous Olympia trial, which demonstrated a 4% 3-year overall survival benefit in BRCA mutation carriers at high risk who received, of course, chemotherapy with or without endocrine treatment. And you can see that almost 95% of these women were treated with anthracycline-based combination. And last but not least, of course, there was 100% receipt of anthracyclines in this important Keynote 522 trial that demonstrated the benefit of adding pembrolizumab to a very strong chemotherapy backbone given prior to surgery in triple-negative breast cancer patients. Argument number 5. Anthracyclines are smart cytotoxic drugs able to induce immunogenic cell death. More than 10 years ago, basic researchers in France revealed a powerful mechanism of action of anthracycline and also of oxaliplatin. These drugs are able to induce a selective calreticulin cell surface exposure, which functions as a eat me signal, meaning that this will attract dendritic cells. They will present tumor antigens to tumor-specific CD8 positive T cells and result in immune activation. Now, the recent and quite elegant tonic trial conducted in the Netherlands brings added value to anthracycline in this era. This was a trial conducted in metastatic triple-negative breast cancer, and it investigated 4 different immune induction strategies given as a 2-week window prior to treatment with nivolumab. Now, it's a relatively small randomized phase 2 study, so we are not authorized to compare the different arms, but you will recognize that the activity of the anthracycline in this trial was the most impressive. And following doxorubicin induction, upregulation of immune-related genes involved in PD-1, PD-L1, and T-cell cytotoxicity pathways was nicely demonstrated. Argument number 6, our ability to mitigate anthracycline cardiotoxicity has greatly improved, particularly in the last few years. So let us first examine what is the magnitude of the problem and again review the information coming from the EBCTCG meta-analysis. So what does this meta-analysis teach us in terms of long-term anthracycline toxicity? Well, it was reassuring to learn that non-breast cancer deaths were not increased with the anthracycline regimens, including deaths from cardiovascular causes. The overall risk of other non-breast primary cancers was similar between anthracycline and non-anthracycline containing regimens. There was, of course, one additional acute myeloid leukemia case per 700 women treated with anthracyclines. Now, of course, you perhaps don't die from cardiac failure, but it's really not nice to live with heart failure. This will seriously compromise quality of life. So, what is the risk our anthracycline-treated patients face in terms of irreversible cardiotoxicity? I think that one of the most informative studies in that field comes from the European Institute of Oncology in Italy. This is a prospective, relatively recent trial that enrolled more than 2,600 patients, half of whom had breast cancer. Left ventricular ejection fraction assessments were done periodically at baseline and then every 3 months during chemotherapy, and for the following year, and then every 6 months. The median follow-up was 5.2 years. Cardiotoxicity was defined as an LVEF drop of at least 10 points, together with an absolute LVEF value below 50%. And what you see is that the incidence of cardiotoxicity, defined in this way, was 9%, but with early detection and prompt therapy, 82% of the patients who developed cardiotoxicity recovered a normal left ventricular ejection fraction. And there is further progress on the horizon. First of all, in the recent literature, you can see that there are early signs of cardiac damage that can be detected before a drop in LVEF occurs. These are, first of all, new echocardiographic signs that are more sensitive than LVEF, and they include diastolic function and global longitudinal strain. Cardiac biomarkers are also useful, and you see there are a number of them that can be measured. And then very recently, there are novel circulating biomarkers that look promising, such as circulating cardiomyocyte cell-free DNA and a number of circulating microRNAs. And second, we have some evidence that early intervention with cardioprotective agents is helpful. And one of the largest randomized placebo-controlled trials conducted in the field relatively recently was a trial in patients who received trastuzumab after anthracycline. And in this particular trial, lisinopril, which is an angiotensin-converting enzyme inhibitor, or carvedilol, which is a beta blocker, were both able to cut the risk of cardiotoxicity in half. So I believe that today we can prescribe anthracycline in a very responsible way, and in collaboration with cardio-oncologists. The first thing we need to do is to screen our patients for well-known cardiac risk factors, and they are listed on the left in the column. Of course, age is one of them. Then a number of comorbidities have to be taken into account. In my practice, if I have a patient who has more than 2 of these risk factors, I will tend not to prescribe anthracycline. What we should also do is, of course, at baseline measure LVEF and global longitudinal strain and circulating biomarkers, because these parameters could identify high-risk patients who do not have the typical comorbidities, who will need a cardio-oncology consultation, and who might start cardioprotective therapy with the very first cycle of anthracycline. Now, during monitoring with these parameters, if we see any worsening, cardioprotective therapy has, of course, to be initiated promptly. And the last argument was already mentioned by Hal. Anthracyclines remain a major affordable component of breast cancer therapy in developing countries. So, as you know, a significant number of breast cancer deaths occurs in developing countries. And here's a comparison between Brazil and Belgium. So in Brazil, as you can see, you have more than 88,000 new breast cancer diagnoses every year and over 20,000 breast cancer deaths every year. This compares with the small country Belgium where I live, 11,000 new breast cancer cases per year and 2,362 breast cancer deaths. But what you can see is that all these powerful, expensive targeted drugs that we would like to use everywhere in the world and that we are discussing in this meeting, they are not reachable in the public health system in Brazil, while they are in my country. And so, being able to prescribe these very efficacious anthracycline-based regimens, which are relatively cheap, is a blessing in many parts of the world, including here, for example, in Rwanda. So, to conclude, I believe that anthracyclines still play an important role, particularly in triple-negative breast cancer at intermediate or high risk, in luminal breast cancer at very high risk, and they should probably be considered, indeed, in some very high-risk cases of HER2-positive breast cancer. It requires good evidence to promote an effective therapy, and I hope you will agree with me that it requires even stronger evidence to abandon one. So, please, Dr. Borges, do not throw the baby out with the bath water. So, I would like to thank you for your attention, and I would like to dedicate this talk to a brilliant statistician in Oxford, Dr. Richard Gray, who greatly helped us with the meta-analysis of all these adjuvant chemotherapy trials, and who passed away suddenly 3 weeks ago. Thank you.
Thank you, Martine. Thank you, Martine. You've repackaged doxorubicin as an immunotherapy drug, so it's no longer affordable around the rest of the world, I want you to know. For the contra-argument here against anthracyclines, Professor Virginia Borges.
Thank you, Hal. Thank you to the organizers for the invitation to debate someone I have admired my entire career, and also for assigning me the argument against. My disclosures. So you heard Dr. Burstein and Dr. Piccart extol the virtues of doxorubicin and epirubicin, and it is clear why we have relied on them for the decades that we have in the treatment of breast cancer. However, I am going to return us to the topic of the negative consequences that these drugs bring to our patients. You see a partial listing of them here, and of course the cardiac toxicity and secondary leukemias are among the most dreaded and somewhat unique of these toxicities. And I would say one of the biggest problems we face is that these drugs put our patients at the risk for these serious toxicities while they do not cure all breast cancers, a very frustrating situation. Let's focus on the cardiac toxicity first. We've heard about some of this from Dr. Piccart already, and we know that these drugs come with cumulative lifetime doses above which we do not want to tread. For doxorubicin, it is 450 milligrams per meter squared, epirubicin 900 meters per square, and this data came from curves that look like this, which shows the takeoff of the significant increased risk for the development of toxicity comes the higher we get with cumulative dose. However, we know that there are patients who will receive lower than these thresholds and still develop the cardiac disease. There's been a lot of work elucidating the reasons why anthracyclines cause this, and cardio-oncology is probably one of the best advances we have in our field to help us manage this. The dominant effect is on the cardiomyocytes with a multitude of possible mechanisms of action, all of which converge down to the cardiomyocyte death, leading us to congestive heart failure. There's also things that occur with the fibroblasts, endothelial cells, and the immune system that lead to inflammation and cardiac remodeling as an adjunct way that this can occur. Now, to be fair, anthracyclines are by no means the only drug that causes cardiac toxicity of what we use in oncology. And as we think about substituting other agents, it is important to remember this. However, for the purpose of my argument against today, please forget you saw this slide. As Dr. Piccart highlighted, we need to look for cardiac risk factors in our patients because those risk factors also predict for who is going to have a higher likelihood of developing cardiac toxicity. Elevated BMI, hypertension, diabetes, pre-existing coronary artery disease significantly increase the risk for our patients and can be readily screened for. More recent research is highlighting for us that those are not the only factors to consider. Importantly, social determinants of health are increasingly identified as contributing to the risk for cardiac toxicity, and, quite frankly, the burden of cardiac toxicity is not equally shared amongst people. Humans of Asian descent, Hispanic, non-Hispanic, Black, and mixed have an increased risk of developing cardiac toxicity over non-Hispanic white. However, when you look at our clinical trials and who we have accrued to those patients over the years, they are most often dominated by non-Hispanic white populations, at least many of the ones we've reviewed today, and so there could be an underrepresentation of the toxicities in some of these larger analyses that we have to focus on as the field moves ahead. Interestingly, it's been shown that there are reasons of genetic susceptibility that some of us may have and have no idea about that could lead us to have an increased risk of toxicity from these multitude of methods by which it occurs. And this could lead to some of those more idiosyncratic cases we see in our clinic for someone who does not meet any of the risk categories. Yes, there are means by which we can both try to prevent the cardiac toxicity, drugs such as dexrazoxane, and also manage the cardiac toxicity, the statins, the ACE inhibitors, the ARBs, and even the SGLT2 inhibitors. However, if we're going to make the argument that one of the reasons we should proceed with using anthracyclines is that they are inexpensive and broadly available, I would say these are not. And so the tools to prevent the cardiac or manage the cardiac toxicity are not going to be there for our patients who are in the most disadvantaged settings globally. Turning now to leukemia, my personal most dreaded side effect of these drugs. It is also a dose-dependent effect, and you see there the takeoff curve for epirubicin with the increased risk of leukemia going up as the cumulative dose occurs. It is true that this is not just the anthracyclines' fault. They are given in combination with alkylating agents, which also cause this toxicity. And you see in the table that the increasing dose of the anthracycline married with the increasing dose of the alkylator agent is basically how we cause an increased risk of leukemia in these populations, so we no longer do those increased doses. The mechanisms of action are also increasingly understood here, and the direct induction of fusion oncogene is the one that is classic for the anthracycline-induced, the others more so the alkylating. When we look at data from the NCCN network about how these toxicities present, you see that they are later, often in their presentation. The risk with surgery is basically the risk of the population of getting marrow neoplasms, and we see that both radiation and chemotherapy and both together contribute to the increasing risk over time. Take note of the fact that many of these happen in the 5 to 10 year timeline, and long-term follow-up is necessary to understand these toxicities. When we look at a study that was able to break out these risks for AML and MDS by anthracycline, alkylating, and taxane-based regimens, we see some differences. Anthracyclines increase the hazard ratio, as do the cyclophosphamide-containing regimens, whereas the taxane regimens do not in either AML or MDS. So when can we confidently not use an anthracycline? I would say in increasing places across the spectrum, and I agree with most of what Dr. Piccart put in her graph on that. I think also the main strategies to avoiding anthracycline is to really focus on giving the chemotherapy to who will benefit from it, giving it to people who will benefit from it in whom there's a more acceptable side effect profile, and also the opportunity to simply not use these drugs and find better options. We return to the meta-analysis that Dr. Piccart introduced us to, and I am showing you the same graphs, but I highlight the difference here in both recurrence of disease and death rates are 2.5% and 1.6%. We are brushing right up against the increased risk of cardiac toxicity and leukemia as combined very negative events later in life for these folks. Also, even when we look at where the data looked the best, the concurrent anthracycline regimens, and you see large separation of curves, I highlight that the cumulative dose is 300 milligrams per meter squared. And when we look back at those hazard ratios that Dr. Piccart show us, it really emphasizes that the main improved outcomes are the ER negative, node positive, younger patients, high grade, and HER2 negative, whereas those hazard ratios did cross 1 for our older patients, ER positive, node negative, low to medium grade, and the HER2 positive. So let's focus by specific disease subset. For ER positive patients, I say we have lots of data to do away with the anthracyclines for these folks. Going back to the ABC trial, as you saw highlighted, to remind you, it's the node negative, node positive, HER2 negative breast cancers. They were randomized to TC times 6 versus anthracycline containing. It is a non-inferiority trial. And the data as presented in 2017 did show us a 4-year invasive disease-free survival that favored the incorporation of the anthracycline. However, if you look at the table where these results were broken out by those patients who were triple negative versus hormone receptor positive, what you see is that in the node negative patients for TNBC, it is a 2.5% difference. In the hormone receptor positive, there is no difference in the node negative. 1 to 3 nodes, it is 2%. And again, this is brushing up the increased risk of serious side effects these patients face long-term and perhaps not meritorious in those cases. We've also become incredibly adept at using genomic profiling for figuring out who even needs chemotherapy in the first place. We had the Taylor RX trial, we have the RxPonder and the MINDAC trials involving patients with positive lymph nodes. MINDAC subscribed the use of anthracycline for patients receiving chemotherapy, where RxPonder did not. We're all very familiar with these data, so I will just highlight that in the premenopausal patients for whom we have decades of research showing that chemotherapy adds benefit, there is an interesting overlap of both studies showing about a 5% benefit for patients with the positive lymph nodes in that younger cohort. However, we know that, well, and I will point out that in the RxPonder data, only half of them received anthracycline-based therapy. And we know that the best treatment for hormone receptor positive breast cancer is endocrine therapy. The women who were premenopausal on the Responder RX and MINDAC dominantly received tamoxifen. We have the data from SOFT and TEXT showing us that if we use an optimized endocrine strategy in these women with ovarian function suppression and an aromatase inhibitor or tamoxifen, we also see about a 5% benefit, suggesting that perhaps these are patients in whom we could even forego chemotherapy if we took this approach. And forthcoming, there are studies such as the OFFSET trial, which will directly help us address this question. I also wanted to highlight the West German study, Plan B trial. It was an adjuvant 4-cycle of anthracycline-containing plus taxane versus 6 cycles of the TC regimen, again, HER2 negative early breast cancer. And they showed the 5-year outcomes for both options were equally excellent. And I show you here the forest plot because of a couple of really interesting reasons. They used a genomic assay, in this case, the 21-gene option. And you see that regardless of whether the recurrence score was less than or greater than 25, there is no difference in the outcomes. Younger or older age, no difference in the outcomes. Nodal status did not matter. Ki-67 and grade did not matter. And even in the triple negative set, there was no benefit seen. The conclusion is that TC is an effective and safe option in the HER2 negative patients, even in the setting of a genomically intermediate or high risk result. So for triple-negative breast cancer, as you might imagine, I won't have quite as much to say. I do want to highlight some excellent work from my colleague, Jennifer Diamond, and her team at the University of Colorado, where I work, and one of our rising fellows, Anna Schreiber. She took the SEER data and examined this in patients who are 66 years of age of older with node-negative, triple-negative breast cancer. They looked at chemotherapy versus no chemo, and they also broke it out by taxane versus anthracycline taxane regimen. And what they saw was that there was actually inferior cancer-specific survival and overall survival when these patients received the anthracycline, suggesting that the favored choice would be a TC regimen ×4 for older patients with low-risk TNBC. They extended this work into older women with node-positive TNBC, and in the 1 to 3 node-positive patients, again, no benefit was seen in overall survival or cancer-specific survival for the inclusion of the anthracycline. That only became apparent with 4 or more positive nodes. Lastly, I'm going to talk about HER2, where I think I can say with the best confidence we've really taken out the anthracyclines. You saw from prior presentation with Dr. Piccart that it goes all the way back to the beginning of the adjuvant trials, where we first had the introduction of a non-anthracycline-based regimen, which came out of the scientific work of Dr. Slayman's lab and Mark Pegram, the TCH regimen. This is the original presentation from 2005, where we saw the difference between the incorporation of trastuzumab with chemotherapy for patients and no difference between the non-anthracycline or anthracycline option. Then pertuzumab joined the team, and we had a flurry of studies in the neoadjuvant space, some of which included anthracycline, some of which did not, and it showed that TCHP was a very strong regimen and really paved the way for it to become a standard neoadjuvant regimen moving forward. From all of these studies, we also learned of the tremendous importance of the tool of pathologic complete response in helping us identify patients who have done well with their prior therapy and are going to remain well versus those who would not, and gave us the opportunity of doing things like introducing additional targeted therapy, TDM1 in the Catherine trial, where we could improve cure rates for our patients with disease that was demonstrating some resistance. So I would say in summary, in the early HER2-positive breast cancer field, my treatment choices look like this. And we can talk about in our forthcoming debate over cases when the anthracycline might still be pulled in. I will highlight that, of course, for patients who are pregnant at diagnosis, we do not want to be giving HER2-targeted therapy at that time, so that's where I'm mainly using it in my clinic these days. So what are the future paths to truly eliminating anthracyclines for all to achieve lower treatment toxicity? I think it's the option of truly tailored therapy, enhanced response tailored making decision trials, like you saw Dr. Piccart highlight the COMPASS PCR, also the incorporation of novel drugs and novel target identification. Another study that we have that is also using this concept of using response of the patient as we go on therapy is the I-SPY 2.2. Many of you are investigators and familiar with this, but I'll just highlight that it is a 3-block treatment approach. Patients get the best of experimental drugs in block A, 12 weeks to respond, extra adjudication with MRIs and biopsies. If the result is looking extremely promising, they can go to surgery right at that time. If not, they can continue on for a second block of treatment, which is the best in class of standard of care or best in class of regimens previously studied in I-SPY. So again, another 12 weeks of interrogating that tumor and figuring out, is it responding or not? The patients then also have the opportunity to go to surgery right then and there. It is only the group of patients who do not have exceptional response after Block A, after Block B, who then will be subjected to the use of anthracycline-containing regimen and bear those increased side effects. Schemas like this allow us to be very rationally and tailored to our individual patient as we make decisions in the course of neoadjuvant treatment. Anyone not getting a PCR, you heard earlier today in some of the presentations about the forthcoming studies that we have there, and they will use some of these novel drugs. For luminal disease, we have the CDK4/6 inhibitors and ER blockers coming. We have the antibody drug conjugates, which are extremely exciting and may pave the way for truly getting rid of anthracyclines, as well as other options. I put here some questions to be determined as the field moves forward, though I think we're more secure in being able to say where we do and do not need to use these drugs now for this debate. I think this topic is going to keep going into the future, and we will see it again come up on the roster. With that, let's get down to the argument.
All right, ladies and gentlemen, you've heard the data. It's time for the reckoning. So I invite you to grab your cell phone, and we have 3 audience response questions here, which will use the Slido format. So if you use this, what do you call these, QRS code, thank you. You can get it, or you can go to the website slido.com and enter that unit number. So while you're doing that, and I see a few intrepid folks holding up their phones, here's our first question. A triple-negative breast cancer in a 46-year-old woman who has undergone breast-conserving surgery and sentinel node biopsy for a 1.8 centimeter high-grade triple-negative tumor that is node negative. Would you recommend TC times 4, TC times 6, or an anthracycline-based sequential regimen? All right, we're looking at a groundswell of enthusiasm for anthracyclines. Here comes TC4 on the back side, turning the glass quarter pole. Okay, keep your phones up. The next case. A luminal B breast cancer, a healthy 66-year-old woman, has a grade 3 hormone receptor positive, PR negative, lower positive tumor, HER2 negative, and has undergone surgery for what proved to be a 2.1 centimeter cancer with 2 positive lymph nodes and a recurrence score of 28. So you're going to give chemotherapy, presumably. Would you give an anthracycline-based regimen or a TC-based regimen 4 or 6 cycles? All right, 2/3 favoring the anthracycline. And finally, for case 3, a HER2-positive inflammatory breast cancer. A young woman presents with inflammatory breast cancer and a staging workup is negative. The tissue biopsy shows invasive carcinoma that is ER negative, PR negative, and HER2 3+, subsequently confirmed to be FISH positive, and there's overt evidence for dermal lymphatic invasion. Would you give TCHP for 6 cycles or an anthracycline-based sequential regimen with THP? And again, it looks like about 2/3 favoring the non-anthracycline regimen here. So let me go to my panelists here. Ginger, are you surprised by those results? So specifically, the use of the, turn the green light pops on. Yeah. And are you surprised by these results? The use of the anthracyclines in a, what would be a very, no use of the anthracyclines or less in a very high risk inflammatory breast cancer, but lots of use in the anthracyclines in a lower stage triple negative.
I'm not sure this is on.
Okay, we can borrow my, here, sit here.
I think this one works.
Yep, I can do this. I think Martine has stacked the audience.
Dr. Piccart will be giving Belgian chocolates out to all those who voted for her at the end of this session.
And so I apologize. I was slightly distracted by my lack of microphone. So you asked
The
me.
question, so we have an inflammatory breast cancer case. Everyone's using TCHP.
Yeah.
We have a stage 1 triple negative. There's still a lot of anthracyclines. Are we getting this the right way?
Well, I too would support the use of TCHP for the HER2 positive case, despite the HER2 positive case, despite the inflammatory nature. I think we see outstanding results there. And as I find those cancers often exquisitely sensitive to the combination. Then we certainly have the fallback of what you could choose to do afterward, including incorporating an anthracycline. So I would absolutely lean in there. I am a little surprised at the enthusiasm for anthracyclines in our low-risk patients. I thought I was more convincing.
Martine, let me ask you, obviously there's still support for anthracyclines. What would you, in talking to a patient, say is a true contraindication? So age greater than 60, the presence of diabetes or hypertension, are there real rules here to say someone should not get an anthracycline?
Well, I have to be completely honest and tell you what I would do in my clinic. For this patient, 63 years old, with a high-risk luminal breast cancer based on tumor burden, 2 positive nodes, and oncotype, what was it? 28. Well, strangely enough, I think I would hesitate to give anthracyclines in view of the fact that age greater than 60, even without comorbidities, makes me worry already a little bit about long-term side effects. But also because with the CDK4/6 inhibitors that produce these more than 6% difference in invasive disease-free survival, I start to wonder if at that age I would take the risk. And then I don't know what people do in this room, but I give bisphosphonates to postmenopausal women at high risk. And I simulated this case in PREDICT, and at the end of the day, I thought that probably the benefit of the anthracycline regimen will be really small. And so this is perhaps the patient where I would not give it. Now, the young woman is a difficult situation. In my clinic, I see 2 types of patients. Patients who want to do everything. They have young children, and the 2%, because it's 2%, the advantage if you use PREDICT, it's only 2%, they will want to take it. And then you have young women very scared. They don't like chemotherapy. They want to do everything possible to avoid chemotherapy. And there I do something which is not evidence-based.
No one record this. Let's hear this.
I go to see my pathologist, and I ask him if there are lots of TILs around the tumor. I know I shouldn't say that, it's not very good, but it's not in guidelines. But there will be a day where we will base decisions on this, I think. And if there were a lot of TILs, I know the prognosis is very good, and I would not push so much for anthracycline. Sorry.
Ginger, let me follow up with you. The question of a younger woman who needs chemotherapy for a luminal B cancer, where do the anthracyclines fit in your mind at that point?
Well, Hal, as you know, the majority of my patients are 45 and under. Many of them are below the threshold for which there are screening protocols, and so I treat a lot of stage 3 breast cancer, multiple nodes, all the way up to level 3 axilla, or even infra and supraclavicular. So in those patients, if they are ER positive, I still think there is a role for anthracycline-based treatment. I am not as much of a fan of TC times 6 because I think we see some added toxicities of the docetaxel, the fatigue that can linger, the chemo brain that can linger, and also that's where we get into permanent chemotherapy-induced alopecia territory, and not all of our patients can afford the cold cap sparing devices to help prevent that, and that is quite the luxury of the United States, I realize, to even bring that up. So that's where I certainly see the role. Again, of course, in the TNBC space for the higher stage patients, we've seen such outstanding results with Keynote 522. It's really quite inarguable, even though I'm not supposed to say that in my position here today. So that's where I am still quite routinely ordering the drug.
Let me just explore that question of the number of cycles of TC, because the studies that looked at TC largely use 6 cycles of TC. In our own practice, I would say we more frequently use 4 cycles as our standard. There was sort of a split vote here. So if you were to give TC, is the correct answer 4 or 6 cycles of TC? Martine?
You know, based on the EBC-TCG work, it's difficult to defend 4 TCs. The statisticians in Oxford were really very negative, and they consider that the cumulative dose is important. So I'm I'm using TC times 4 in older women. But big frustration is the fact that we have not been able to identify biomarkers predictive for anthracycline efficacy. And in the pre-taxane era, we did Dr. Bartlett had a very nice initiative. He pooled the biomarker results of 5 trials comparing CMF to anthracycline, and he could demonstrate very strongly that there were 2 biomarkers associated with a very significant advantage of anthracyclines. It was topoisomerase 2 aberrations, deletions or amplifications, and duplication of chromosome 17 centromere. But of course, he could never confirm this prospectively. Then the taxanes arrived, and there we are without biomarkers. I think it's a shame. We should do a better job there. It's a real pity.
Let me ask just a couple more questions. Ginger, the question of HER2 heterogeneity comes up frequently in our tumor boards. So we saw a big vote in favor of not using anthracyclines in an overtly HER2 positive cancer. For the cases where the HER2 expression is 2+, or there look to be pieces of it that are not so robustly FISH positive, is that a situation where you might think about an anthracycline-based regimen because you want to cover it, or is the TCHP regimen sufficient?
So I think the onus on us to make sure the way the pathology is being interpreted in the setting of HER2 heterogeneity is incredibly important, and we will see cases that come back as 2+, and then they're in that gray zone on their ISH test, and so going and testing another area of the tumor, if available, talking to the pathologist, again, going down and sitting at the microscope, or these days it's projected on the board. It really is a requirement to make sure you believe you know what you are doing. Having said that, when we look at the outstanding results from these clinical trials, they didn't really parse, right? Positive was positive. Where I would say I will lean in more on an anthracycline regimen in a non-pregnant patient is we often have folks who show up with 2 tumors. And it's incredibly important that all sites of disease are biopsied, that we understand what the markers are, and we all have cases of someone whose 1 tumor is bona fide HER2 positive and 1 is not. And that tumor, the second one that's not, may even be a candidate for a genomic analysis, such as the 21 or the 70 gene, and then based on that tumor's result, you have to make the decision, does that tumor need chemo? We know the HER2 positive one does, and then if the answer to that is yes, it's kind of a good marriage between anthracycline followed by taxane and HER2 targeted drugs to cover both problems. So that's where I've used it most recently.
Martine, let me ask the final question to you. We've done a lot in the way of what many folks call de-escalation, where for lower risk breast cancer, we've been able to avoid chemotherapy altogether, and in certain instances, we've been able to pull back. But for higher risk cancers right now, we're actually doing a lot of escalation. We're adding biologicals, immunologics, second anti-HER2 drugs, CDK4/6 inhibitors, and all that kind of thing. If you were to be advising investigators who are looking at what's going to be a high-risk treatment platform, where you're already piggybacking in antibody-based therapies, immunologics, what will be now several years of a CDK4/6 inhibitor, that kind of thing, is it time to just concede that 1% to 2% squeezing the towel for anthracyclines, that we should pull that out and look for better things, or do we still need to use this as a building block?
That's a tough question. I am not participating in I-SPY, but I think that at least in the first generation of the I-SPY trials, they built the investigation of the new drug on a backbone of anthracycline and taxane, right? But has that changed now?
Yeah, it's changed.
It has changed. So, yeah, it's perhaps an indication that we could imagine a platform where we drop the anthracycline, because we are coming now with very fancy drugs, presumably active and expensive.
Well, please join me in thanking 2 wonderful speakers, and
That's nice.
have a good afternoon.
The chocolates.